It's going to be okay.
You'll be fine, inshallah.
In the UK, some 5 million major operations are carried out every year.
Nerves are kicking in now. Good luck, we've got it.
We'll keep you safe, okay?
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
There's adrenaline,
Knife, please.
anxiety,
Lock on, please.
but as soon as you make the incision, everything goes.
Let's focus.
Serving Edinburgh and the surrounding area, NHS Lothian pioneers techniques to treat conditions that few others dare to take on.
You can consider it as a ticking time bomb.
But the cutting edge of modern medicine presents huge challenges.
Every time we operate, there is a risk that things can go wrong.
I'm in difficult territory.
Stop. Don't want to go any deeper than that. I think we'll damage her.
Anything less than perfection
We have a bit of a bleed.
can have grave consequences.
Tube clamp. Tube clamp.
The surgeons
Looks very abnormal, doesn't it?
bear the ultimate responsibility.
We can't offer 100% success in everything that we do.
Take that away from me. Give me this, thanks.
You wouldn't be human if you didn't feel the pressure.
You need to be very quick now.
You okay?
This is what really happens behind the closed doors
That's a big chunk of the tumour.
of their operating theatres.
You've done something for this person that can prolong their life.
Beautiful. You can see the pulse.
You're waking up, everything's gone really well.
It's one of the biggest privileges
I've got good news.
to help people the way we do.
The Western General Hospital in Edinburgh is one of Europe's largest specialist centres for colorectal surgery. 400 bowel cancer operations are performed every year by some of the most skilled surgeons in the country, including consultant colorectal surgeon Danielle Collins.
Before a big case, I like to clear my head by going for a run and maybe rehearse the steps and think about what you're going to do if something unexpected happens. I was really young and I wanted to do medicine because I remember wanting to do it all through secondary school. I did go to visit a hospital and see a toenail being removed and fainted and was very upset because I thought my whole career was misdiagnosed.
Danielle's next case is so complex, she has enlisted the help of consultant Vula Granitsiotis, an expert in urological reconstructive surgery.
Danielle has a good sense of humor. She can be sharp, and she's a very dynamic surgeon. We're working so close together that it's like speaking to a friend all the time.
You will call me when you need me for a second opinion.
Yeah, and something that's so complex, you really want to have the best people around the table. I think what she underplays is her skill and her ability to really put anything back together if I take it apart.
Their patient will need Danielle's skills to remove a life-threatening tumour and Vula's skills to repair the defects it has left behind.
She had a bowel cancer 2 years ago that was removed, and now she has a recurrence of this rather aggressive tumour.
– 75-year-old Joan lives with her husband David in Kirkcaldy in Fife. They have been married for 54 years.
He found me. And then I found him. And then we got married and we thought the streets are going to be paved with gold. Oh, lovely. I had David at my side and that was all that mattered. Thank you.
We don't go anywhere without each other.
Don't get much cake these days.
We are just a couple that's done everything together.
Joan has only recently recovered from her initial bowel cancer surgery.
It's hard for her to go through another operation after only 18 months ago.
We ready, David?
Yep. We're quite frightened of having it, I think.
It was a shock. In fact, I thought, do I really want this? because I thought a long time of sort of getting yourself back together again. David says if anything was to happen to me, he would not be long after me. So...
God knows what we'd do if she wasn't there.
So I have to do this for both of us.
It's situated right at where the bowel has been rejoined from her previous operation.
The tumour is attached to the bowel and 3 other adjacent organs: the vagina, bladder, and left ureter. It has also nearly doubled in size in 2 months, which means this is an urgent operation as well as a complex one, with life-changing consequences.
I think if we had to do a joint of the bowel that was very low down, I think function might be an issue in terms of continence and incontinence.
Her previous operation removed a section of bowel. Taking out this tumour will mean removing even more, and so Joan will need a colostomy.
What about bladder?
Where the ureter runs through the tumour, it's right at the corner where it goes into the bladder.
I think the primary here is that we will assist you to take as much as you need to achieve clearance of the tumour and then trying to reconstruct.
This is one of the most radical operations that we would consider doing.
The operation will be in 2 stages. First, Danielle will cut the bowel and left ureter above the tumour. Then she will be able to dissect around the tumour, ensuring no cancer is left behind by also removing parts of the organs it's attached to: bowel, bladder, ureter, and vagina. But she must be careful to avoid major veins carrying blood from the lower body to the heart. Once the tumour is removed, Vula will repair the bladder and reconnect the ureter that drains urine from the kidney, before a colostomy procedure brings Joan's remaining bowel to a hole made in her abdomen.
We'll anticipate that we may have to have a couple of options for repairing.
The operation is radical, but necessary to save Joan's life.
If we don't do an operation, there's a risk that it could grow enough to either block off or obstruct the bowel or possibly lead to some kidney failure. In addition, there's a chance it could spread to either the liver or the lungs, and that would be a situation where we wouldn't be able to get a cure.
But with the tumour so close to major blood vessels, it's an operation with significant risk.
Worst case scenario would be having some catastrophic hemorrhage that we wouldn't be able to control. That could be a fatal complication for Joan.
You don't let me carry that wee bag, do you?
Why?
No.
He said there was no...
So I would say I feel more anxious this time than I did the first time.
All set for today?
Yeah.
Any questions or anything at all?
You do what you do best. That'll be good with me.
Okay.
8:30 a.m. Across the Western General's 11 theatres, operations are being prepared. In Theatre B, Danielle is briefing her team.
We'll open, we'll do an anesthesialysis, and then we'll mobilise where the tumour is and work out what we need to do from there.
If I'm being given the chance to get an operation and a surgeon who is magnificent, then I am going to take it with both hands.
Try and think some nice thoughts, all right, as you go off to sleep.
Knife, please. As far as
Yeah, close.
Assisting Danielle is Senior Registrar Helen Ewan. She makes a 30-centimetre incision from the pubic bone to the sternum.
Good. Helen is somebody I trust to have on my case and to work alongside. She understands how to remain calm and collected in situations under pressure. Still scar tissue from a previous surgery. That's us in. When you're doing reoperative surgery, one of the difficulties is that you aren't 100% sure of what's happened before. It's a bit like going in to rewire a house in that you need to find out what was done previously. That's still small bowel.
That's colon.
Yeah, so that's colon there, okay.
Joan's operation 18 months ago removed part of the bowel and uterus, and scarring has stuck different tissues together.
And there's another loop coming in.
That loop that comes there. The challenge is trying to work out where things are and where things are supposed to be, and then using your background knowledge of the scans and the anatomy to work out what you need to do next.
Danielle must locate the tumour.
You can only do it by feel. It's hard to see.
But it's deep in Joan's pelvis.
Yeah, let's just take a view of where we're at and let go for a second. So you can, if you put your hands around this, you can feel the mass now. Come around the whole thing. Deeper down.
Okay, yeah.
It's in there. When you first get your hands on the tumour, going through your mind is it mobile and what's it attached to? And do I think I can get this out or without causing fatal consequences?
Is it pretty deep down?
It's deep, yeah.
Specialist skills are needed for the most complex surgeries. At the Royal Infirmary of Edinburgh, Orwa Fowler takes on some of the most challenging cases referred to him from across the country.
The first time I saw in a journal this type of surgery that I am doing at the moment, I thought, wow, this surgery is possible to do in a human being.
Orwa's next patient is about to undergo an operation so high risk that 1 in 10 doesn't survive.
This patient is 72. She's at the extreme of that I would consider doing this type of surgery.
The patient's aorta, the body's largest artery, is weak and could burst at any moment. A condition called a thoracoabdominal aortic aneurysm, which affects fewer than 6 in 100,000 people.
Thoracoabdominal aneurysm is less common in women compared to men. And if they develop an aneurysm, they tend to rupture earlier than men.
3 months ago, after a tear in its inner wall, the top section was replaced with a synthetic arch called a frozen elephant trunk because of its shape.
So this is the frozen elephant trunk which already been done.
But the tear has continued down the rest of her aorta, and blood has prized the internal walls apart, nearly doubling the aorta's width.
The problem specifically in her case that her aneurysm in the abdominal aorta has increased rapidly and massively and now measures 7 centimeters.
The aneurysm, or bulge, means his patient now needs an urgent operation to replace the aorta's full 30 centimeter length.
If it's left untreated, it would have a high chance of this burst, and if burst is instantly fatal.
I still can't believe that I've had this.
Isabelle lives in Kilmarnock.
It's like living with a ticking time bomb. You just don't know when it's going to go. Right, Scabby Queen, let's get the pears out first. Okay. No cheating. I like to have fun. I don't think I have the same fun with my children, but I do with my grandchildren. I wind them up something terrible. That's me. Winner!
Well done, Ken.
They light up your life, they do. I get a lot of good memories of them. And hopefully a lot more to come.
Isabelle's situation is one she understands only too well. 5 years ago, her husband David died suddenly from the same condition.
I try not to think about it too much because it would drive me nuts if I did. David used to always make things better, and I've not got him to speak to. Living by myself It's been quite frightening. I really, really miss him.
She's terrified of the way he went and how that could happen to her. It's not nice to hear your mum saying, I'm terrified, like, I'm terrified to go to sleep at night. She is really living life on a knife edge right now. We all are. I don't know what we would do if they couldn't operate on her. We would have no hope, you know, but now we do. We've got such a huge hope.
This surgery, I would consider one of the biggest surgery any human being can have, replacing the whole aorta in one operation.
Isabelle's operation is high risk and extremely complex. First, Orwa must access and expose the full length of the aorta from next to the heart all the way down to the pelvis. He will replace it using a synthetic tube. In the midsection, he must also rejoin the critical arteries that supply blood to Isabelle's major organs: the liver, stomach, spleen, pancreas, bowel, and kidneys. But he will have just 1 hour to complete all the connections before the organs start to fail. Only then will he be able to complete the procedure by attaching the tube to arteries in her pelvis.
This operation is very risky because cutting the blood supply on these important structures can carry a huge risk for the patients. The blood loss is massive. We're talking about liters and liters of blood.
I feel sorry for you because you're going to be worried sick.
Well, listen, I'm not. I'm happy that the team are all there. I'm every faith
I know,
and every bit
I
of
know
it.
you have, I know that.
Isabelle is very determined to have this aneurysm fixed and survive this. Hello.
Hello, Mr.
How are
Farmer.
you?
Nice to see you. I'm fine,
Nice to
thank
see you again. All ready for tomorrow?
As I'll ever be. Nervous.
You're allowed to be nervous. Any questions?
No, as I said, I've got every confidence in you. I know you're the top of your game.
Thank
and that's
you.
all I can ask for.
It's a big team involved.
That's it.
It's a big team, it's not just me.
Thank you.
Thanks for saying that.
Staff across the Royal Infirmary's 28 operating theatres are preparing for surgery. In Theatre 18,
Today we're doing open type 2 thoracoabdominal aneurysm.
Orwa is briefing scrub nurses and support staff with consultant anaesthetist Ewan McGregor.
She's probably a slightly higher risk than average in terms of complications, just her fitness, having had that big operation 3 months ago.
Any questions?
Okay. Thank you, everybody.
I normally sleep really well, but the night before these operations, I do find I tend to wake up early before my alarm clock, partly with a feeling of a bit of excitement, but also a feeling of there are so many tasks ahead of us.
See you later. I just want it done. I don't want anything to happen. I've come this far. I'm almost there. Let me get to the end of the road and then I'll go out and paint the town red.
You're doing fantastically well. We'll be taking very good care of you, okay?
Ready, steady, sugar.
These patients put full faith in you to be able to fix their problem, and you always have to do your best. It's a huge weight on my shoulder.
1, 2, 3.
Isabelle is placed on her side to access the full length of her aorta.
What we're going to do is we'll angle this one a wee bit more.
Okay, start.
Yes, thank you very much.
Orwa begins by making a 70-centimetre S-shaped incision, starting at the bottom of the shoulder blade, going across the ribs and down to the navel.
This incision is the biggest incision for any operation you can perform in a human being. You literally have to split the patient in half.
Clear the lung. Lung is clear. Can I have the rib cutter, please?
Orwa cuts through Isabelle's rib in order to move her lungs aside to access the aorta.
The exposure is massive. You have to expose the whole aorta, up in the chest, the abdomen. All the arteries goes to liver, bowel, both kidneys.
I think the abdomen is open nicely there. I need to preserve this for the spinal cord. Okay. Be gentle with this because they easily dissect these.
As he exposes more of the aorta, Orwa marks vital blood vessels that must be preserved.
Yeah, gentle.
You have to maintain a decent blood supply to the spinal cord. If you get injured, it can cause massive bleeding. The worst thing can happen to the patients is to get paralysis and be in a wheelchair for the rest of their life.
Abdominal exposure is complete. Aneurysm.
After 2 hours, Isabelle's aorta is fully exposed and ready to be replaced.
We're all good to go.
Excellent. Right. When you do this big surgery, they always put pressure on you because you always want it to go as planned and the patient survive it. Not each surgery goes smoothly as you think.
And the forceps, please.
At the Western General,
can we get a bit of light in here?
consultant colorectal surgeon Danielle is attempting to remove a tumour from deep in Joan's pelvis.
We found where the tumour is, so we just need to free everything up first and then get down from behind it.
Its location means taking parts of 4 different organs as well. But doing this may impact Joan's quality of life.
You don't want to be so radical that you cause more complications than you need to by taking away extra healthy tissue, but at the same time, you don't want to compromise a healthy margin of tissue and not take out all the tumour. That's one of the major challenges of this type of surgery.
Danielle divides the bowel so she can more easily access the part attached to the tumour.
Yeah. There's just not really going to be enough length to put things back together again.
When she removes the tumour with part of the bowel, what's left won't reach the rectum. Danielle will carry out a colostomy procedure later.
Okay, that's good.
Now she has to cut the ureter, the tube draining urine from the kidney, because the tumour is attached where it joins the bladder.
It's a balance between ensuring that I don't take the ureter where it could be attached to the tumour, but leaving enough to make an easier reconstruction. That's going into tumour just there, so if we take it, can you pull this towards you that way? Yeah, that's good. Right, let's do it. Anybody else want the honours? No. Scissors? Stand with. So that's the left ureter divided. Yeah. I'm thinking, well, that's one point of no return. I do think about Vula a little bit, but I think the main aim is to get the tumour out, and then we can work out how to reconstruct things afterwards.
Danielle has to carefully work her way through tissues in the pelvis and towards the back of the tumour.
Just behind you, right, is the external iliac vein, that thing there. So you just want to be really careful not to put too much tension or traction on it. The blood flow coming through the iliac veins is all the blood volume from the leg and the pelvis. And so if they do bleed, you get brisk bleeding that can be quite difficult to stop. You're at a point where things could get hairy quite quickly, and that everybody knows to expect that. The vein's not far away there, actually. I'll just need to really go slowly as I dissect around the back part of where the tumour is. Matt, we have a bit of a bleed. The first thing in your mind is trying to stop the bleeding, and usually that just means putting a finger on where things are bleeding. I just don't want to take my finger off your suction please.
The bleed is coming from the internal iliac vein.
I'm just gonna look at this more. Okay, can I get a stitch, please? So can you just stay like you are for a minute, okay? It is a huge weight of responsibility. If something unexpected or untoward happens, everyone's looking to you to fix it. Can I wait? No, just, yeah. You have to fix this. There's no alternative. Just so I can see my needle, that's what I want to do.
The bleed is deep within the cavity.
Show me the needle. I can't see the needle. As I put the stitch in, I can't see the needle coming out for the amount of blood that's there. So what I try and do is get my assistant to suck directly where my needle is going to come out. So suck over here, please. And then suck over to the left. Yeah, and just... It's a bit like a dance, you and your assistant, and you need to be moving with the same rhythm. Yeah. Yep, and away.
With Helen's help, Danielle is able to stop the bleed.
Well done.
Scissors, please. We've got it. Come out with your other retractor and give your hands a rest. Yeah, let your heart rate come down a bit.
Danielle still needs to free the bladder and vagina from the tumour mass. But she's found another problem.
There's a big vein at the back. It's running through the tumour. Yeah. You realise that things are more complex or more challenging than initially expected. The internal iliac vein is going into and through the tumour. That kind of raises the anxiety level a little bit, in that I could end up with a bleed that might be really, really difficult to control.
In Theatre 18, at the Royal Infirmary, consultant vascular surgeon Olwer has exposed the length of Isabelle's aorta, ready to replace it.
When you repair the whole aorta, you have to shut the blood supply so there's no blood going to the rest of the body. The way to maintain this blood supply is to put them on a bypass machine. Start bypass slowly.
Going on bypass slowly?
Yeah, slowly.
The bypass machine will divert blood from Isabelle's heart and return it via the femoral artery in her groin. It will flow back up her aorta to supply her vital organs. Olwer will then be able to replace the aorta in 3 stages. First, he will attach a new tube to the frozen elephant trunk from Isabelle's previous surgery. He must shut off the blood flowing from the aorta to Isabelle's major abdominal organs via 4 branch arteries, and then cut out a patch so he can join 3 of these arteries to the tube in a single procedure, before attaching the 4th artery that supplies the left kidney. Each connection must be done quickly, or Isabelle's organs will begin to fail. Finally, Olwer will attach the end of the synthetic tube to the arteries supplying the lower body and allow blood to flow once more.
Right, okay, all ready? Clamp on. Clamp on. Right, have a knife, please.
With the first section of diseased aorta clamped, Olwer can cut away tissue to access the frozen elephant trunk.
Gush of blood now. Good.
The aneurysm is open and there is a lot of bleeding taking place. We normally anticipate losing 20 litres of blood plus for this kind of operation. Most people would have, on average, around 5 litres of blood in their body. So this is losing all of the blood in your body 4 times over.
During major surgeries like Isabelle's, patients are given a blood-thinning agent to prevent clots forming. But this also increases bleeding and the risk of life-threatening blood loss. To combat this, a revolutionary machine called a cell saver is used to salvage the patient's own blood and infuse it back into them.
So these are the reservoirs for the cell saver.
Saving on average 1.5 litres of donated blood per operation.
We use it for obstetric operations, we use it in cardiac, we use it for liver transplants, major vascular operations. It's an amazing bit of kit.
Stephen trains theatre staff how to operate it.
Tricky bit is to actually get this lined up. So it spins freely, you know that it's in the right place. Yep, perfect. The way to think about cell salvage is just 3 stages, okay? So the first stage is collection. So you collect the blood in the reservoir, and the reservoirs have got a filter in them. During the operation, if there's any big clots or, any gunk or anything, the filter will capture that.
A bag of blood is used to demonstrate how the machine works.
For the benefit of you guys, we've got some expired blood, but you need to pretend this is a patient, okay?
During surgery, blood being lost is suctioned from the patient. Once debris or clots are removed by the filter,
as you can see, the reservoir can fill up very rapidly.
It's then passed to this centrifuge, which separates the vital red cells that carry oxygen around the body.
How does it separate the red cells?
Basically, the red cells are the densest component of the blood. So when the centrifuge is spinning, the red cells stay at the bottom of the centrifuge.
This cell saver, inspired by the dairy industry's process of separating cream from milk, is used in the Royal Infirmary and beyond.
Once there's enough red cells within the centrifuge, the machine has to wash the red cells in saline before it gives it back to the patient.
The revolutionary equipment takes some pressure off blood banks, which in recent years have seen a significant drop in blood donations.
It's amazing how a lot of people don't realise that we are actually able to recycle patients' blood. It's amazing to see, people's faces that they, this actually happens, and we are actually able to do that.
In Theatre 18,
Frozen elephant there?
Yeah.
Orwa has cut away tissue to expose the frozen elephant trunk in the first stage of replacing Isabelle's diseased aorta. Isabelle's new aorta is made from woven polyester impregnated with a gelatin sealant to prevent blood from leaking out.
Meticulous surgical technique is very important. When you attach the surgical graft, you do it in a way that should be a watertight one.
Just to check it just now.
Check the top end, okay?
Okay, thank you very much. No.
Just see how the graft will lie because. Okay. Yeah. I think we're done with the chest now.
Now, he faces the most dangerous part of the operation, replacing the section of aorta that includes the branches, known as the visceral arteries, that supply Isabelle's abdominal organs: liver, stomach, spleen, pancreas, bowel and kidneys.
Everybody understands in theatre that this is the most critical part, and everything needs to be done very quick.
So would you guys happy for me to clamp this one?
The longer Isabelle's organs are without blood and oxygen, the ischemic time, the greater the risk they could suffer catastrophic damage.
Okay. Clock on, please.
We have 1 hour to do all this. We call it the golden hour.
Knife, please.
Your level of stress goes high when you shut the blood supply to the abdominal organs and when the clock behind you is counting.
The major organs are connected by branch arteries to the aorta. Orwa needs to cut out the section of aorta where they join it. He'll create a patch of 3 branch arteries and then attach it to the synthetic tube in a process called anastomosis.
It takes a time to prepare this area before you start the anastomosis. So that will be included in the golden hour.
Okay, right. What's the time?
6 minutes 34.
Once the synthetic tube is in position, Orwa can make a hole for the 3-artery patch to be joined. He has to be careful, as he's very close to vital lumbar vessels that supply Isabelle's spinal column.
While you're doing it, you keep checking the clock, but at the same time, you have to do it in a way that works. So it's a combination of you have to do it fast and you have to do it perfect.
Leave a lot from the back if it's not working, okay?
Stitching on the patch has to wait. A lumbar vessel is bleeding from somewhere behind it.
At that point, you have to be very quick in dealing with this, identifying where the bleeding is coming from.
If I don't see the organ, I won't be able to do that.
A bleed from a lumbar vessel could starve the spine of blood and oxygen, causing paraplegia. Isabelle has already lost 6 litres of blood.
Stay there. I need to take my stitch. Stay there. What's the ischemic time? 24 minutes. 24 minutes.
Until the patch is in place, Isabelle's major organs have no blood supply, and the golden hour is ticking away.
You have to have very strong mental capacity to deal with this. You have to think about the patients. If this doesn't work, it's a major problem and can cause them to die.
This is not good.
In Theatre B, at the Western General,
A stitch, please? Yep. You got that? Yep.
Danielle has cut around the tumour, taking parts of Joan's bowel, bladder, ureter and vagina. The hole made in the vagina has been stitched closed. But a major vein, the internal iliac, is running through the tumour itself.
Why is it going into tumour?
Like, I don't know. Suck. What you didn't want to happen has happened. Am I going to be able to remove this tumour or not? Down a deep dark hole, sorry. Yeah. I can't just pull it off, and I don't want to dissect into a vein. If I get a lot of bleeding, I need to be able to control it. And the only way I can control it is if I can see it. And the only way I can see it is if I have removed the tumour. There comes a point of no return. Bit of bleeding now. Can I have an arch clip, please?
Go back here.
I don't have a choice but to take the specimen out now.
Just hold this back for me.
Danielle clamps the vein to slow the bleed. But she'll have to remove the tumour before she can find the source of the bleed and stop it.
Just pull this back. I'll get the wire out of the... please take the wire from in between the handles. Thank you. Take that away from me. Give me this. Give me this. Thanks.
You have to have faith that you're trained to do this type of surgery. It's just you in that moment and what you've been trained to do. You're not thinking about anything else.
So. Scissors, please. Thank you. Give it to me. Let me have.
Specimen. You look at the specimen and you realise that it looks to the naked eye and to touch that you've removed it and the tumour. It is a real sense of relief and an achievement that you've managed to remove it. But what's left then is just the clamp that's on the vein. Once you remove the clamp is when the bleeding will start again.
Yeah, slowly off, very slowly. Good, yeah. Need a stitch, please, Vivian. Sorry, I can't see it. Get the light in, please.
With the tumour out of the way, Danielle can see the internal iliac vein and where she has to stitch to stop the bleed.
There is a sense of urgency to get the patient off the table, and that you've had a lot of blood loss, you're aware it's been quite a long operation. There's still a reconstructive part of the operation to do.
And a bit of pressure and it'll be fine. Is she okay? We have control. We're okay.
Well done.
Everyone breathe. Great.
That's the toughest part of the operation over, for me at least.
Hi.
Hello.
6 hours into the operation, Vula arrives to start the reconstruction phase.
Do you want me to show you, or do you want?
Yeah.
Yeah.
No, all right. You always feel a bit apprehensive that you don't want to let anybody down, that suddenly you can't find a way of joining things together. Can I move the light a bit?
Vula's first job is to repair the hole in the bladder caused when Danielle removed the tumour.
So we have the defect here.
Just there.
From a difficult position, okay. So we start from here.
Exactly.
Okay, guys.
With the help of senior surgical fellow Elena Segui, Vula uses surrounding tissue to plug the hole and reinforce the bladder wall.
No. Take this out. And do not move. All right, give it up. And we'll do one more there.
Any leak could cause a serious infection.
That's yours. All right, so that's what we have. The bladder is closed. So, Elena, the ureter is here.
The bladder is fixed, but the ureter that Danielle cut must be attached.
I always hope for the simpler procedure. And in some cases, we simply move the bladder and connect the ureter in it. The simplest thing we do sometimes is the best and the easier outcome for the patient.
But the gap between the bladder and the ureter is too big. Vula must come up with a different solution.
One of the attractions for doing this form of surgery is that you need to be thinking on your feet.
Okay. Right, so let's bind the bullet into the flap.
Vula will solve the problem with an ingenious technique. Using a section of the bladder wall, she will form a flap. This will bridge the gap between the bladder and the ureter. The ureter will be passed through the flap and the extension stitched closed, restoring urinary function.
Okay, so Elena, very careful there. What we cut now is irreversible.
The decision you take to where to cut, how long is the flap you're cutting, is a final decision.
Can I have a marker pen, please?
Take into account, of course, that the bladder tissue is expandable, so you don't want to cut a very big flap because then you are reducing maybe the bladder capacity afterwards. But you don't want it too short because you don't want to have tension. If it's tension, then the stitches can go away and the blood supply is disturbed, so it doesn't heal well.
Here.
If this part of the operation fails, it will affect Joan's quality of life. In addition to a colostomy bag for feces, she would need another one for urine.
And can I have a small forceps for me? I don't do big.
Fair enough.
At this stage. But guys, 1, 2, 3.
Closing the bladder defect that it was made for the cancer bit of procedure, and then having to go and open another hole, it's a bit ironic, but it has better results.
Well, the good news is that already the bladder is holding. Give me Babcock.
It's a relief that you can see even immediately after the stitches have been placed, that urine can accumulate the bladder. That means that the repair at this point of time is holding well.
Good. You have anything more delicate this time? Oh, nice and little. Okay? Right. So, position of bladder is there. Flow to the side. I can pass it through, no problem. Okay.
The flap has extended the bladder, and now the ureter must be attached to it.
Make sure it's coming straight, guys.
You have to find the right position for the ureter to go through the wall of that flap and comes inside.
All right, everything needs to go down now. Oh, brilliant. Keep everything down. That's all I want you to do.
Vula's ability to reconstruct is really impressive. There is a bit of an art to it, I think, and I think that she's finessed the art of urological reconstruction.
Good. So guys, it doesn't look bad. It's tension-free, really. You can see here. Back of the bladder is fine. Plenty of fat here. Okay, bye.
Bye, thank you.
No problem.
I have done as much as is in my power and my knowledge to help Joan achieve a quality of life that it is as normal as possible.
Danielle can now complete the colostomy procedure. She diverts the remaining bowel to an opening in the abdominal wall and places a bag over it to collect the waste.
It is one of the more challenging operations that I've done.
But you're bloody fantastic.
Somebody comes along to you with a problem that you know that you can help them out with. You get satisfaction from helping people through it, but also I enjoy the challenge of these types of cases and really pushing yourself to see what you can achieve.
Joan, can you open your eyes for me? That's your operation finished. Can you hear me all right? Yeah, that's a nod. That's great. I'll grab the door if you want.
It's taken a 6-strong surgical team 10 hours to remove the aggressive tumour and repair Joan's bladder function. She'll spend the next 4 days in intensive care. In Theatre 18 at the Royal Infirmary of Edinburgh.
Where's the needle to come?
Here. Yeah.
Right, so give me access.
Orwa has controlled the bleed from the lumbar artery, but he's running out of time to connect Isabelle's vital abdominal organs to her synthetic aorta.
Okay, I'm just taking my needle there. See that coming?
There's no blood going to these organs. The longer you leave them without blood, they will fail.
To reconnect the vital organs, Orwa must join the 3-artery patch to the synthetic tube.
If you're not executing that part of the surgery very quick in a meticulous way, it can impact badly on the patient's outcome.
No, I'm good. I'm going. Yep. Hips are free.
The 3-artery patch is complete.
More hips out.
Orwa forces a saline solution through the tube to check the connections and clear any blood clots before allowing blood to flow again to Isabelle's vital organs.
Okay. Clock off.
41:53.
Yeah.
Within the golden hour.
Okay, right.
You relax in terms of the liver is secured, the bowel is secured, one of the kidneys is getting blood.
But while the organs Isabelle needs to survive are getting blood, there's one more artery to attach.
The other kidney still needs blood, still pressure you to do this.
Let's do that and kill me. You can be very quick now. Yeah.
Patients have 2 kidneys, and you can survive with 1 kidney and avoid dialysis. It's always best to have both running, so you have to maintain the blood supply for both.
The one animals.
The artery for Isabelle's second kidney is attached to the tube with a length of surgical graft.
Okay, let's get this coming.
And blood can flow to it once more.
She's stable?
She is.
The riskiest parts of the operation are over. Now Orwa can move to the final task, joining the synthetic tube to the arteries supplying blood to the pelvis and legs.
Okay. We have it bleeding. You need to be prepared for every challenge. But you can have a cardiac arrest and death.
The 3-artery patch he joined to the synthetic tube isn't holding.
Bypass, go down, half a liter.
Reducing the blood flow from the bypass machine will slow the bleed, but it won't solve the problem.
If we're running the bypass circuit at a low flow, there can be a risk of clots forming. So that's what we really have to avoid. And we need to make sure that the blood is very thin. That will add to the difficulty for Mr. Fowler to try and deal with this bleed.
Sit down, please, quickly.
The stitches have cut through the tissue of the 3-artery patch.
Doesn't matter how good you are, still you can be faced with a case that tissue is very friable. And we describe it in our surgical terms like cheese when you stitch.
We are almost on a bit of a knife edge and making sure that there's enough blood in the heart and getting around the body to get blood to the brain and all the vital organs.
I need to get in.
The only way to stop the bleed is to stitch where the 3-artery patch is torn from the synthetic tube.
I have a major blood loss, which is very difficult to control. Is this correction going to work or not? If it doesn't work, you have to redo it again. And that would put the patients on a greater risk. So it's a bit stressful situation you have to deal with.
Okay. Give me a cough with plan, please. Another one. Yeah, butter 3 off, please. Quickly, quickly.
There's no hesitation there. Any hesitation can make the situation worse. You never show your weakness, that there is a problem that you're not able to fix.
Using stitches buttressed with Teflon, Orwa can apply pressure, stop the bleed, and reinforce the patch.
You guys happy?
Yeah, we're happy. We're happy.
You can have problems that you have to fix, but you have a bit of a relief, and the repair is sound.
Let's try the bottom end now.
Orwa can finally connect the end of the synthetic tube, completing Isabelle's new aorta.
Okay, when you're happy.
We're happy. We're
Time
happy.
to go
Thanks.
bypass.
Yes, please.
Right, okay, clamps, please.
Her own circulation restored, Isabelle can be taken off bypass.
And then come here. Valsalva off.
Valsalva's off. Thank you very much.
Pulmonary catheters out. You okay?
Constant blood loss during the operation has required transfusing 22.5 litres of blood.
Looks nice.
Final checks complete, the wound from navel to shoulder blade can be closed. 11.5 hours after the operation began, Isabelle will go immediately to intensive care, allowing Orwa to call her daughter.
Hi, Len. It's Mr. Fowler here. We just finished. We're just getting here ready to go to intensive care just now. You know, it's still early days. It's a big surgery, and the next few days will be very critical.
It's 7 weeks since Isabelle's operation.
I'm so proud of her and for being so brave and for going through it all and for it worked. The operation was a success, it was great. We just didn't foresee everything that's kind of happened after it.
Following her surgery, Isabelle needed kidney dialysis and she contracted sepsis and pneumonia. Setbacks that have kept her in intensive care.
She's fighting hard. She's conscious and alert, she's communicating, but still requiring support from a ventilator, which is something I won't like to see a patient staying on a ventilator for a longer time, because the longer you are on it, you get more problems. You always have to have the honesty when you perform this complex surgery that you performed it the way that should happen and dealt with the potential problem. And if complication happen after that, is you ask yourself, is that the result directly to something I have done to the patients, or is this just, this is one of the things can happen after this surgery? You always need to have insight to answer that question correctly.
At the minute, we're having to take every day as it comes and have to be right behind her. We said to her the other day, come on, Mum, you've got this, or are you still hanging in there? And she just nodded and smiled, yes.
It's been 3 months since Joan had her surgery.
David, could you come and take the flowers, please? Thank you.
Miss Collins told Joan that she had taken a biopsy and they had checked it and there was no cancer left. She was clear.
Both of us just think how fortunate we are and that we should be so grateful that, you know, everything went well, because it might not have done. I'm delighted. You just know in yourself that you're getting a lot better. Just getting back to normal, really normal. You know what we should do? Get a map of Europe, stick a pin in it. If you're waking up, you're still here, and of course you've got to make plans for the future. Here's to your foreign holiday.
It's a nice feeling that you've done something for this person that can prolong their life and that they can have a reasonable quality of life, hopefully cancer-free. Yeah, that is a nice feeling.
Next time.
Gas, 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 gas.
Life-saving heart surgery on an elderly patient.
Ian doesn't have a second chance. You put your finger back this time.
Where there's no room for error.
Cardiac surgery is a really unforgiving surgery.
Just gonna shake the heart a bit.